panel that we're going to get into today is going to be talking about eliminating health disparities in your community through the use of Z codes. So today we're going to have two speakers. I'm going to introduce both of them right now, and then we'll get into it. But to start with, we have Karen Bartrom, who is the Director of Clinical Integration and Documentation. She works with the case managers and social workers to secure the best outcomes with safe, appropriate patient transitional plans. She's got over 24 years of hospital case management experience, where she's focused on innovative ways to improve the delivery of care. Karen believes complete and accurate documentation is the foundation in telling the patient story to all of those providing care. She knows the importance of a complete and comprehensive assessment for each patient to help identify opportunities to improve health and wellness, and she's an avid follower of healthcare legislation and Center for Medicare and Medicaid Services regulations that impact patient care and discharge planning. She's recently secured new programs at Cameron, including general inpatient hospice, chronic care management services, and palliative care. It is this holistic focus that improves the lives of the patients in the Cameron community. She holds a master's degree in nursing with a focus on health education from Regis University in Denver, Colorado. She's been certified by the Commission for Case Management since 2011, and she's a member of the American Case Management Association. Along with her, we'll have Madeline Wilson, who is a quality and patient safety advisor. After serving for over 30 years in the nursing field in acute and ambulatory settings in quality, risk, regulatory, and patient safety, Madeline decided to take her passion for zero harm to the next level by using her skills in change management both at the state and national level. She assists hospitals in harm reduction with performance improvement initiatives, educational resources, and culture of safety coaching. She's also serving as the Health Equity Lead for the Indiana Hospital Association and has assisted hospitals with the development of systems to track social determinants of health through Z-code tracking to better identify the needs of their communities. She's a member of the Indiana Sexual Violence Prevention Council and has been trained in the Indiana Trafficking Victims Assistance Program. Madeline also holds a master's degree in nursing with a focus on healthcare policy and advocates at both the patient and hospital level. So with that, I'm going to turn it over to them now so that we can get started and digging into this topic.
Thank you for that introduction, David. We're going to start with me, Madeline, first, and then we're going to hear some great things from Karen Bartrom, and you'll be really excited to hear her story. I'm going to begin sharing my screen here. All righty. Well, as David said, I'm Madeline Wilson, and I serve as a Quality and Patient Safety Advisor and Health Equity Lead at the Indiana Hospital Association. I am very honored to be able to share some of the work that we have been doing at IHA with several of you here today. Just hearing the stories, the awards, my heart is so touched. I just have a love for critical access hospitals, and I thank you all for letting IHA be a part of your journey and all the work that you do. So let's talk a little bit about what we've been doing at the Hospital Association. And so I know that, as I said, several of you are already engaged in a lot of our grants, but I kind of wanted to give you a high-level overview of a few other projects that we are doing with several of you as well. At IHA, our quality improvement work is centered around grants, 3 of which are grants that support health equity through the identification of social determinants of health and data tracking. Our first grant, which is a HRSA grant, it started in 2019, and it was through the Small Rural Hospital Improvement Grant Program, or the SHIP program, and it was called a Special Innovation Project, or as we call everything, as in abbreviations and letters, it's SIP. So this uses the hospital's community health needs assessment to focus on a targeted community need and start the screening process to capture Z codes. Our second grant, which is called Safety Pin, which is our perinatal improvement program, stands for Protecting Indiana's Newborn, supports Indiana's goal of reducing infant and maternal mortality by finding gaps of care through social determinant of health screening with our maternal population. And the third grant, which Pam talked a little bit about, is named the Indiana Healthy Opportunities for People Everywhere, or the IHOPE grant, which is funded by the CDC and was awarded to IHA by the Indiana Department of Health's Office of Rural Health. And that has a goal to reduce COVID-19 health disparities among the populations that are really high risk in all of the rural communities. So as a refresher, I kind of want to go backwards a little bit. Let's first start with some definitions as we talk about social determinants of health. Social drivers, which are also known as social determinants of health, are conditions in the places where people live, learn, work, and play that affect a wide range of health and quality life risks and outcomes. However, the word determinant suggests that really nothing can be done to change our health fate, right? And so by saying social factors drive our health, we kind of reframe the conversation about health. So this is going to be kind of a new way of talking about social determinants of health. So this really shows that social factors that don't force health to be fated or destined, but rather it's something that communities and people in those communities can overcome or change, and that's with our help. When we consider how we can address these social drivers of health, there are several key factors we consider, and some of those are the income and social protection, working life conditions. Here's one: social inclusion and non-discrimination, unemployment and job insecurity, education, access to affordable and good quality health services. And this is another one which I've spoken to many of you about in the past before: early childhood development. And I say this is really important because with some of the tracking that we're currently doing right now with our hospitals and Z codes, we are seeing a large amount of these factors being reported for childhood adverse experiences. Structural conflict, food insecurity, housing, basic amenities, and just the overall environment that people live in. As you're going to see here in a couple slides coming up, there are some specific ICD-10 codes that are linked with all of these social factors, and they could really help you begin some community-facing program engagement. When we consider the impact of these factors and we break them down, looking at this picture here, you can attribute 50% of them just to where you live. Education, employment, income, family and social support, living in a safe neighborhood with clean air and water, and having the ability to live in a safe home and just leave your home to go where you need to go are all very significant influencers when it comes to good health outcomes. Think about some of the stories we're hearing right now on the news. If you have any apps on your phone, I don't know how many times these pop up on my phone about things that are occurring in the middle of the day sometime in all of the communities that we live in. You know, these drive-by shootings or these just crime events that are happening, and really they're happening in historically safe neighborhoods that we've always known. And it's just a different kind of violence that's occurring all over. So when you think about these circumstances, I challenge you to look at it a little bit differently. How might that be an influencer on how someone attempts to take care of their own health? Are they afraid to go outside, to walk outside for exercise? Are they afraid to go to a grocery store? Or perhaps they're afraid to be seen because maybe they have a family member that's engaged with some of these bad activities. So we don't know what's going on with these people unless we ask them. And so that's why this screening is so important. Just on October 3rd, just a couple days ago, CMS released an updated health equity framework. They have 5 priorities that really inform us of what CMS's efforts will be for the next 10 years and how they can operationalize each priority to achieve health equity and eliminate some of these disparities. Their plan is to use this work to build health equity into existing and new efforts by CMS and other stakeholders, AKA our other payers that we engage with. The first priority is to expand the collection, reporting, and analysis of standardized data. Here, CMS is striving to improve upon and use standardized, individual, level demographic and social determinant of health data, which includes that race, ethnicity, language, gender identity, sexual orientation, disability status, and yes, social determinants of health. Their second priority is to assess causes of these disparities within the CMS programs and address the inequalities in the policies that they have and operations and work on closing those gaps. So we can't accomplish this second priority without the first one, right? With the data collection and analysis. Their third priority is to build capacity of your healthcare organizations and the workforce to reduce the health and healthcare disparities. And I know that's a big like, yeah, that's going to be a challenge, right? We're all seeing that right now. But this is the real important one for all of you and our SIP participating hospitals. They've been hearing me talk about this for about 3.5 years now. This is by collecting this information and doing this work, this is how we can better resource in allocations to support all the work that you're doing in your hospitals. And Pam talked a lot about this, about what can we take to our legislators and what can we take to our public health council, and, you know, by showing them, look, this is a true reflection of what we're seeing in our communities. This is how we can get that funding to help you with these programs. Priority 4 and 5 is the patient side, facing side of the framework. It's CMS's dedication to equity and equality in all the services they offer, and also access for all. So you'll see some expansions on the Medicare and Medicaid and Medicare Advantage programs. So with all this being said, this is not the work of the future, but it's the work of right now. But the SIP hospitals that have been doing this work for the last 3.5 years, they went back to the future and they began doing this work about 3 years ago. Using the Healthy People 2030 roadmap, we designed the Special Innovation Project around the steps of this roadmap that you see here. First, to identify the needs and priority population, community health needs assessment. Second, to set hospital targets individually and as a group. Third, to find inspiration and practical tools. And fourth, to monitor the progress using statewide and national benchmarks for Z codes. The first step in this, what I call very complex process, was to build that multidisciplinary team with hospital leadership being included so that they can support those changes that may need to be done along the way. Everyone's input is so important when starting this implementation because it really does impact everyone's workflow. You need to have a social screening tool in the EMR. So IT's needed to be in part of this team. You need to have a person to do the screening, which could be social workers, navigators, or nurses. Your coders need to be a very big part of this because they're going to be the one looking for these codes. And then this is another very important role, community wellness liaisons. They are the ones that are going to be linking the needs that you uncover in your hospital patients with the resources that are out there in community and building those partnerships. And you're going to hear a little bit more about that when Karen speaks. For the program, we really followed the Plan, Do, Study, Act process, and we utilized the Healthy People 2030 roadmap, which is so very simple. In year one, the plan was established by the hospitals conducting their community health needs assessment. From here, they chose one focus area, just one, even though they might have had several areas identified. But just to make this more simple, one area. And that was probably most of the time the biggest need that they saw. In the second year of the program, the multidisciplinary teams from each hospital were formed, and we began meeting both as a SIP group and internally in the hospitals. We had some educational trainings on social determinants of health. We talked about screening and the different processes and the different programs that are out there. We talked about the system changes being your workflow processes. We talked about all the roles involved, and we talked about the Z codes. And what started out as 14, hospitals with maybe one person from each hospital. We have upwards to between 70 and 80 now team members that have participated in all these activities. And, it was a big learning experience because many people didn't even know what the heck a Z code was. And at that time, IHA, our great data team, was able to build a wonderful database that we could collect all of this information from your claims that you submit to us. And so we developed our Z Code Data Link program. And, that has been very beneficial because we really kind of replicated that on a study that CMS did, where they looked at all the Z code capture from the Medicare claims, and then they linked that with their high-risk populations, and they discovered the low number of social determinants of health Z codes that were being captured that would maybe help support why these high-risk populations were struggling so much. And so we just kind of mimicked that, and we had that put into place. In year three, the teams were focused on adding the screening questions to their EMR and trialing, who would be the best person to actually do that screening. This was also a time for them to educate others in their facility on the importance of this work. They were also introduced to programs that can help them track the resources they were connecting patients to, such as the formal Aunt Bertha, which is now findhelp.org. And then also our own internal great resource, Indiana 211. Workflow started to migrate from one of handing a packet of information to your patient saying, here are some resources if you need help with food or transportation, to actually having processes set up in place where one-on-one interactions and getting these things set up for patients prior to them leaving the hospital are now starting to become a part of the workflow. We also introduced speakers to talk about the changes in the interoperability and the data collection that payers are using, and also new regulatory standards such as what's found in just the most recent IPPS rule. And also Joint Commission. If you're a Joint Commission facility, there are new conditions of participation. We have one-on-one meetings still a couple times a year and then as needed. And we discuss some barriers, and we're now linking hospitals with other hospitals at different levels of where they're at in these programs and learning from each other. So our last year, which is the year that we're in right now, I call it our senior year, and graduation will occur in May of 2023, involves a heavy engagement with multiple community resources. So we're introducing some of these resources that people really weren't aware of what they had to offer. All the various transportation programs that we have throughout the state. We have housing. We're having a couple different iterations for that. We're looking at all the food resources, and we're also building programs that we can use to take this data to our legislators to get more community health support. And, we're at the time now, since this is year 4, that the hospitals will be looking at a new community health needs assessment. So it'll be really interesting to see if we see any changes, especially with the hospitals that are a little bit farther along right now. So how do we identify social drivers of health or social determinants of health? It is with these things called Z codes. And just as a refresher, they're the subset of ICD-10 diagnosis codes that represent factors that influence the health status, but they're coded as a non-medical diagnosis. And, there are hundreds of Z codes in the ICD-10 coding manual, but there are just 9 specific categories that just focus on those social drivers of health. And those are found in Z55 through 65. And as you can see here, here's a list of all these categories and how they are non-medical diagnosis. There are numerous codes that fall between the 55 and 65. And every year that list keeps getting bigger and bigger. So you'll see like Z55.1, 55.2, and so on and so forth. Just recently, on October 1st, there were new codes that were introduced, and what CMS is really looking for, now they're looking for more specificity. So as you can see on this slide here, the examples, looking at transportation insecurity, that was added. Financial insecurity was added. Material hardship. And these are just your basic needs. And so they're really moving things out of the other category, which will really make a big difference too, as we move into ICD-11. And so getting more specific will kind of help us fall into better coding practices. There are 2 resources I've listed here, and you all have the presentation that you can read in for all of the Z codes that we have to date. And believe it or not, we are now up to 114 social determinant of health Z codes that fall in that Z55 to 65 program. So how are our SIP hospitals doing? So this is just a snapshot of our results, and I'm so very proud of them. Just to keep in mind, you all are aware, because your all hospitals are the same size. You might see small numbers, but small numbers link, definitely with, what is your average inpatient stay? And so every positive number is one more piece to maybe finding out what's bringing a patient back to your hospital. The pandemic really impacted some of our sites, and other issues have occurred due to the hospitals maybe being a part of a larger network, and the network having to make that change, and so perhaps they couldn't get their EMR processes really established, or the coding comes from outside of the organization. So some hospitals have moved a little slower than others, only because they have to work as a collective group, but they are progressing. And then, when you look at these numbers, I do just want to point out, in 2020, there were nearly, and this is outstanding in my mind, 1 million less claims from all of the hospitals in Indiana that were submitted, 1 million less claims. So that means there were 1 million less people that came to your facilities for medical treatment. So of course that influenced the denominator, but as you can see, we still captured more Z codes than we did the prior year. But I think that kind of sets the stage for what we're seeing now, that because people didn't get the health care that they needed now, they're coming to us sicker. So, we learned through all of this that this was not easy work. And there are challenges. And some of those challenges included some of the obstacles, like the data collection in itself, understanding the definitions of these social drivers, and also clinicians being a part of that team, and then coders knowing that they can, in fact, use other documentation outside of what a doctor documents. And so this was a whole new learning process, and also a tracking process for coders. Also, the operational issues that came into play. Many did not have any type of screening tool built into the EMR. And also, we kind of had to flip, getting away from that thought process of these codes do not contribute to any financial incentive to collect this information. But that's changed. And, now we have regulatory moving into that process as well. So we really kind of need to move away from that. And so there have been some recent updates out there, and I know many of you are already aware of this. Excuse me. CMS is incorporating health equity into their payment systems, including the Medicare Advantage patients. Also, this is being incorporated into a lot of the private payers. So I don't believe that this is a flavor of the month, that this really is the way of what our coding is going to look like. And as I mentioned before, the Joint Commission is now established a new accreditation standard that's going to be effective January 1 of 2023. So this will be a condition of participation. And for those of you who are interested in what Leapfrog promotes, they too have incorporated health equity into their scorecard. So, I know that some folks ask, how does all of this help my patients? I have sent you a link here. This is a really good white paper, quick read for you to look at. It was noted in this white paper that over 70% of US hospitals do not screen for key social needs, despite it being a time when interventions to address them really may positively impact a patient's health outcome. The social determinant of health screening, may provide some valuable insight into your patient care. It could maybe change how you provide care for your patients. And also it changes how you facilitate that post-discharge care. And, this is a no-brainer. It also, you might be able to see that, by not screening these patients, it could contribute to that excess utilization of your emergency room use and even your inpatient services. You might need to keep patients, an extra day or two. And also, it really can worsen your existing disparities in those post-discharge outcomes. So really, they truly do matter. So when you're considering the risk of a patient in your hospital, and you're thinking about, is there an opportunity for a safety event occurring at your hospital with these patients? Also consider what social influencers can increase that risk in your hospital. Do your patients understand, why they're taking the medications that you're giving them or those treatments, or even understand why they shouldn't get out of bed? Linking that back to what Mitzi brought in, the health literacy and that understanding. We can't assume that people understand all of this. Do they have family or friends to stay by their side to keep them in bed? We've had so many big changes with, visitation and even families not wanting to be in a sick place, right? So there's an increased risk. And, also, we're just hearing stories. There was just another one yesterday that broke my heart about the challenges that hospital staff are facing with safety and people getting harmed. And so, not only the story that came out yesterday, not only was the patient harmed, but 2 nurses were harmed. And so we're just looking at a different environment right now and the mental health link to that. So all thoughts to ponder. So with all of this being said, I'm now going to turn the slides over. I'll be flipping them to Karen Bartrom from Cameron Memorial Hospital, who's going to share their hospital journey through this whole process. And I think you're going to love this sharing, and I think you're going to learn a lot. And so, Karen, I'm now going to start sharing your slides for you.
Okay, thank you, Madeline. So, yeah, I'm just really happy to share some of the journey that we're on here at Cameron. And by no means has it been perfect. Have we? We've kind of stumbled a few times. We've had to kind of pivot. Had some agility around what we thought was working that was not working. So just happy to share where we are now and where we've been and where we hope to go. So next slide, please. So this is really kind of our why. We know every patient has a story. And part of what we at Cameron want to do is we want to learn our patient's story. We want our patients to trust us enough to tell the story of what their obstacles are, their barriers, what those challenges are when they're, at home prior to coming in. So we really started with this why, and how can we build a program around spending time with our patients and truly learning their story. Next slide. So just in our time together, just wanted to share, like I said, where we got started, some of the obstacles that we've had, what are our strategies, what technology do we leverage, and then where do we hope to go. So, next slide. So before we get started, I just wanted to share where we're located, and we're in the northeast corner of the state and in Steuben County. Steuben's known for having 101 natural lakes, and I just think it's a beautiful county to live in, work in, and so just really excited to share some of the work we're doing. We are a critical access hospital and independent. Next slide. So our work for social determinants and social drivers really folds so beautifully into Cameron's vision statement, where we do want to leverage technology and partnerships and promote just overall health and wellness in our community. Next slide. So where did we get started? Really, I would, hands off to the Indiana Hospital Association and Madeline's work with us, because I'm one of those, Madeline said earlier, you may not have ever heard of what a Z code was. And it was over a year ago when I really learned for the first time what a Z code was. So we were doing the work of collecting just patient assessments and hearing our patient's story, but we were putting it more in a narrative form. And we know that the coders were capturing some of the work that we were doing intentionally in the social work arena, but didn't know that it actually equated to a Z code. So just really excited to learn that element, that with the work that we were doing, we knew we could quantify in some way. So the education to the coding specialists, we have hospital employed coders, and so they did participate in the education that Madeline spoke about. And that really helped kind of kick off our journey of seeing an uptick in our data. So we also have just a clinical integration team, and that's the social work, case management, utilization review. We also partner with so many of the other clinical staff here at Cameron. And we had an organizational readiness. Everyone was willing to jump in and just get started on this journey. So next slide, please. So really, we wanted to make sure that we were not only doing the work that was going to equate over to the Z codes, but we wanted to make just assure that we were getting a customized care plan together for the patients. So it's one thing to do the work and to check a box or click a box, in a discrete field, but we have to do something with that information. So we wanted to make sure that that was connected. And if we're asking those questions and we're learning that there's an obstacle and a barrier that might be a resource or a service in our in our community, that we're connecting, we're building that care plan for our patients. We also expanded over into the emergency room. So we wanted to make sure that we had some support for patients who really come in for a non-medical reason. Maybe it's a social need, basically. So how can we make sure that we're assessing those patients and getting them connected to outside services? And then what could a consistent workflow look like? So we would have this sustainability across just different areas of the hospital, or even on the ambulatory side. So still a work in progress of building this framework, but we feel as though we for the most part have a really good grasp on what this workflow is. So next slide. So this is from the Indiana Hospital Data Link database, as Madeline spoke about. And the numbers here are not true. I know there was some adjustments with the software recently. So from the time this was submitted, some of the data was not entered in here. So second quarter is still, it's out now. But when you look at 2018-19, we weren't really focusing on capturing of the Z codes, but where that red line is in 2020, second quarter, is when that education occurred with our coding team. Then we really did start seeing an uptick in the Z codes that we were capturing. Next slide. So, you know, who the stakeholders are here at Cameron, and really the answer is everyone on the clinical team is participating and helping us with formulating this, like I said, framework around how can we not only do the inpatient in our swing bed program, but how could we expand over into other areas that are still a little bit under development on the physician side. So it just really does take a village to pull this together. Next slide. So I did want to kind of share what systems we have. And next slide, please. Our electronic medical record, we have a vendor, a large organization who does, we contract with for our software. And, you know, there's sometimes limitations to that, because what we had hoped to maybe have that would really fit our environment, our culture, isn't necessarily readily available. So, you know, we were looking for ways that we could create a workflow and a process that was intentional. We could put our information into a location that could then be easily recognizable by the coding team. So that meant discrete fields. And so we did identify that, and I know that the vendor is also working on updating. This is more of the social determinants of health module in the EMR is brought live, that we know will have more discrete fields for that work that we're doing. Next slide, please. So what we don't have, I know in this EMR, there's other modules. We do not have the population health module. We don't have the case management module. And we don't have that single portal view where you can kind of see the patient's care across the entire continuum. Next slide. So what we've kind of learned along the way. And next slide, please. So we really started with just brainstorming. We wanted to do not only look to see where this information could live, but we wanted to make sure that where we thought the information was actually getting picked up by the coding team. So that was kind of some tracers we had to put into place where we thought as clinicians, oh, the coders will be able to see this and this is all going to be readily available for them. It didn't necessarily always work that way. So we did have to make some adjustments and some changes, and really feel as though now we've got a pretty good process around getting that in a centralized location that not only saves time for the coders in just seeing what that screening tool looks like, but to also allow us to have that information readily available for any of the clinicians that are taking care of our patients while they're here in the hospital. Next slide. So we did have the opportunity to have two highly trained specialized social workers, and one one social worker spends her time up on the floor. She's med surg. She also does the work for discharge planning around our transitional care unit or our swing bed. And then we were able to expand over into the emergency room and kind of even go outside the bricks and mortar of the hospital and start supporting our providers' offices for patients that might be calling in that need something. They've got a social determinant need, and partnering that social worker to not only do that assessment, to capture the information, but to get the patient set up for the needs that they have. Also, just the high utilizer. We do have some patients that come into the emergency room often, and many times often it could be that they don't have a medical need, it's more of a social need. So how can we support them in a way that you've got a social worker who can really focus on that work for the patients. And then we have a chronic care management company that does assist us with patients on the ambulatory side. And they also do a social determinant screening. And if they've got some things that they need to make sure the social worker follows up on behalf of our patients, then they're making referrals to the social worker. Next slide, please. So this is a screenshot of the discrete flow sheet that's in our EMR. And many times, even at the beginning of our work, the coders were sharing that often this was blank. And I really kind of believe that we just didn't know this flow sheet was there. And now that the flow sheet is there, this is where the information goes from the social work team when they are working with our patients and they're asking these questions and putting this information in as a repository basically for the work that's being done, so that it can be viewable across other areas of Cameron's patients' care in the providers' offices, and et cetera. So next slide. So what we wanted to do was, we knew the flow sheet lived in a certain area of the chart, but with the social work team documenting in their template that's all around doing a lot of this assessment work, which is so basic to case management and social work, of really trying to understand the patient's their obstacles, their barriers, all of those things that they really struggle with to try and stay healthy and happy. And so we wanted to make sure that we pulled that flow sheet into the area where the social worker was actually doing the work. This centralized everything for any clinician that knows where that note lives to go in and see not only what that assessment is, what's the social determinants or the social driver indicators that are picked up, and then what's that customized care plan that's been developed by that social worker. Next slide. So we added a dot phrase. And so it's in the template, and it literally just automatically pulls it over. It's not something that the social worker has to remember to go over and copy and paste or pull over in any way. It is an automatic function. And we have had some providers who've also adopted this, and we know we have more work to do and opportunity around having more of the clinicians actually utilize this function as they're working with our patients. Next slide. So this is an example of this dot phrase or this smart link, and how the social work team is pulling their information in as they're creating it, and then the social determinants of health comes over after it's been filled in on the discrete field side. Next slide. So what other programs are we working on? Like I said earlier, we've expanded to the emergency department, and it's made a significant impact on really just coordinating with patients and providing additional resources and services to allow them to be successful outside of the hospital setting. We've got the high utilizer. We do often get referrals from the emergency room staff. There's just chart review for screening, and the social worker who spends her entire day there just meeting with every patient and doing these assessments so we can set up success. And then, yeah, just from the med-surg side, we've got the social worker who does do the bedside rounding with the hospitalist, and they incorporate that assessment of the social determinants of health. It's pulled into the record, as I had shared, and then just setting up the counseling that's really, once again, customized to what the patient's needs are. And then we also do a follow-up phone call in the emergency room for the patients that are actually interacting with the social worker, as well as up on the floor within 48 hours. And that's really a structured call as well, and templated, so that we know that the follow-up that was initiated on the inpatient side has some continuity around that follow-up phone call. Next slide. Our transitional care unit, the swing bed program, but the emergency room and inpatient social worker actually do complete this full assessment for patients that are either coming over. Many times if they're transitioning from our inpatient over into our transitional care unit, there is a command, it's that dot phrase that pulls that over because the work has been done for this particular hospital stay. And if it's an external patient, then the full assessment's done much like it is on the inpatient side. And the next slide. So the provider offices is something that we're pretty proud of, because we're able to support the providers for some of the patients that have just a higher need. Maybe it is a social need. They're calling in because something's changing in their life. They're not quite sure how to handle that. And we really haven't historically been able to support the providers' offices and the patients. We might see them in the emergency room, but we want to try and get in front of that. So this really allows this relationship between the providers and the social work from the emergency room to support those patients, complete that social determinants of health assessment, and then customize a plan for provider services or support from other agencies. Next slide. Our chronic care management company also helps us with capturing not only the monthly conversations that they're having with our patients, but they also do a screening for us when there's a patient who's coming on service, and maybe there's a life change, something's changing with them that's been discovered in that monthly call with the nurse care manager. And then just the mechanism of how the physician's office can be notified of that, how the ED social worker could be notified to follow up and customize on that patient. So what more can we do? We know we've got opportunities to expand. And really what we did was we just didn't wait for us to have a perfect plan to jump into this program. We kind of just got right into it, tried to see what worked, what didn't work, what we needed to change, and feel as though we're better than we were a year ago. And we know a year from now we're going to be hopefully much more improved. Next slide. So we do know we want to expand into other areas, and this is all kind of a work in progress. So, we hope to get into some of our providers' offices and work with the whole Cameron Medical Group team to make sure that the patients are being asked these questions and then supported through customized plans of services and resources that they need. Next slide. So I love this quote, because I really feel like stories are everything, and stories are really going to help us as an industry learn what's best for the communities. And then, it's looking through the lens of someone else. What we think to be a need in our community may not necessarily be the need in the community. So that's where the stories, kind of flow over into Z codes that really can help us see the bigger picture more than just through our eyes. Next slide. So as Madeline talked, there's a lot of legislation out there, and this was one that I had followed. Really don't have an update on what this one is. Maybe Madeline does, but I love looking to see, what's Indiana doing around promoting the practices of capturing just these health disparities. Next slide. So part of what we're doing in the community and what we've learned is, yes, we're doing our community health assessment here in 2022. We've also identified in some just of our preliminary Z code data that we have a couple different areas that seem to be relatively high. And one of them we didn't really necessarily pick up until we had run some internal data in our EMR that some of you may be aware that, you know, there's only so many slots available on a hospital claim. And, you know, the Z codes may or may not, they may be captured by the coding team, but they may not necessarily land on the claim. But in our EMR, we could run a report of those codes that were actually captured. And it really kind of gave us a different insight of other areas that we didn't necessarily know were an issue. And we suspected mental health, but we thought Z code Z60 was our highest captured code, but it turns out it's really Z code 59. And with the social and the living environment. So we've been able to work with our social work team and kind of go outside the walls of the hospital and begin some programming for the community. And that some of it's around mental health. Some of it is around other like community supported events. We are doing connections with our post-acute providers. So just a lot of exciting work that's happening, and you know, we just are happy to share the journey that we've been on, and I thank you for your time. Appreciate if you have any questions. You know, certainly I kind of hit the high level, but if you've got any more detailed questions that you might have, I'm certainly happy to answer those. Thank you.
Thanks, Karen, for sharing that amazing journey with everyone. As Becky had mentioned in the beginning, everybody should have gotten this presentation. It's chock full of resources and also the contact information to reach out to Karen or myself should you have any questions. Once again, to all the SIP hospitals, congratulations on moving in a great path. And I'm sure there might be some additional hospitals with us today that might be knocking on your door. So I will turn it back over to you all. And as I said, please feel free to reach out to either of us for any questions.